morning, everyone. Welcome to the IMF live online patient and family webinar. I'm Robin Toohey, Vice President Support Groups, and along with Susie Dury, President and co-founder of the International Myeloma Foundation, it's our pleasure to welcome you. In this online webinar, you will learn about the latest treatments for and management of myeloma. Panelists for today's webinar are Dr. Brian Dury from Cedars-Sinai Medical Center, Dr. Rafat Abenauer from Indiana University, Dr. Paul Richardson from Dana-Farber in Boston, and patient advocate Yelak Baru. Today, you'll have the opportunity to ask questions. If you do have a question, please click on that question box and type in there, and we will do our best to answer your questions. If you have not yet accessed the slides, you can do so at myeloma.org. And additionally, to help you better understand some of the slides, we've included links to the myeloma terms and definitions and also myeloma acronyms commonly used. Before we get started, I'd like to thank our sponsors for their support of today's webinar: Amgen, Binding Site, Bristol Myers Squibb, Genentech, GlaxoSmithKline, Janssen Oncology, Karyopharm Therapeutics, and Takeda Oncology. It's now my pleasure to turn this call over to Dr. Brian Dury.
Well, thank you so much, Robin. And before we get started, I don't know, Susie, if you want to make your own welcome, just to, I know that you're especially pleased that we're able to have this GoToWebinar instead of the BOCA seminar.
Yes, hi, can you hear me?
Yes, yes.
So thank you very much, everybody, for getting on this very important call. We're very excited that we could still do this seminar virtually, and I know that you're going to hear a lot of really good news and advances that are being made in myeloma. So, and of course, we're always here for you, so never hesitate to contact the IMF if you have any questions, concerns, or ideas. So, Brian, it's back to you.
Thank you so much, Susie. Thank you so much. So let me just say as well that I'm so grateful that Rafat, Paul, and Yelak have agreed to join us. On my first slide here, you can see sunny California. Unfortunately, it's been incredibly cold with rain and storms, so bad that we actually lost the power at our house. And so this is not quite California today, I'm afraid. We are very grateful to our sponsors, as Robin mentioned, and we appreciate that they have been very, very supportive of our need to shift this from the two-day event to this GoToWebinar. So thank you so much for your support to all our sponsors. The format today will be that myself, Paul Richardson from the Dana-Farber Cancer Institute, Boston, will be joining me. Do you want to say hi, Paul?
Yes, good morning, everyone. And it's a pleasure to be with you, Brian and Susie and Robin. Thank you so much for making this possible, and a very warm welcome to all our patients.
Thank you. And Rafat Abenauer from Indiana, very pleased that you can join us. You want to say a word, Rafat?
Yeah, good morning, and thank you for having me. It's right now snowing in Indianapolis, so I would rather be in Boca Raton, but I'm glad you were able to pull this seminar together to help our patients. So good morning, everybody.
Thank you so much. And Yelak, are you back home in Arkansas right now?
I am in rainy and cold Arkansas, and I'm delighted to be here. And I look forward to an engaging discussion throughout this webinar.
All right. Well, thank you all. And so in this current crisis situation related to the coronavirus, I think that it was definitely necessary and appropriate as we move to slide number 4 to have this as our first topic for discussion today. And so you'll see that on slide number 4, I've listed the coronavirus as topic number 1, followed by frontline therapy, which will include the pros and cons of autologous stem cell transplant, maintenance therapy, the types, and the issues related to continuing or changing or stopping maintenance, approaches to relapse focused on the use of approved drug combinations, and then the information about the exciting new novel therapies. After each of these segments, there will be comments from our panel, and then it will, as Robin mentioned, be possible for you guys to type in questions on the question bar, and we will see those and try to respond to your questions. All right, so if we move to the first topic, the COVID-19, this virus that emerged at the end of December in 2019 and has had such a devastating health impact in these last few months, and is now reaching a really serious crisis point for us all here in America. And if we go to slide number 6, a key point for all of us to be aware of are what are the telltale symptoms of the coronavirus. Well, it is what's called a respiratory virus. It's one which does affect primarily the respiratory system, at least as a first area of attack. The vast majority of patients who are infected do run a fever, so 90% of the time, if you have an active infection, a fever will occur. The cough, which is linked to the coronavirus, is more of a dry cough, a deep cough, and that is because this is not like a bronchitis. This is an inflammation that is occurring within the lungs, and so that's why the coughing is more of a dry and of a deep type. And then this is linked frequently with a really significant increase in malaise or tiredness. A main thing to be aware of, at least certainly outside of the United States, symptoms that would resemble having a cold or a flu usually do not occur. So it really is a little bit different. There isn't like a runny nose or the typical flu-type symptoms. This is really rather a different pattern of symptoms. If we go to the next slide, what I've listed here is what I think is really the key thing for patients with myeloma right now. Now, just to be aware, this is the first time that I have ever written a blog 3 weeks in a row on the same topic. So for the last 3 weeks, I have written a blog about this COVID-19 coronavirus. And I wrote the most recent blog on Thursday, but I also had blogs in the last couple of weeks in which I've given a lot of detailed advice for patients. And the key point right now is that since there has been a limited access to coronavirus testing right now, the big dilemma actually for all of us in the U.S. is that we have very little knowledge about who might have infection or have been exposed to infection and who does not. And so this really makes it very, very difficult to know among your friends or family or contacts who might be putting you at risk for possible infection. And so this notion of what is called on slide number 7, social distancing, is really quite important. And for myeloma patients who are definitely what one could call vulnerable, myeloma patients have reduced immune systems. Because of the various treatments that we use, the immune system can be further suppressed and the white count can be knocked low by treatment. And so this is a particular problem, especially since myeloma patients may be more elderly, the average age being above the age of 65. And so this is not a time to be cavalier. This is a time to be staying home for now. To avoid infection, hand washing, very important, and avoid touching your face if you feel that you may be in an area where there could have been surfaces or contact where infection could have been lurking. Contact can be with through your eyes or your nose. It's good in areas where there may have been a surface contact, to avoid touching your face. Wherever you are, at home or traveling, clean the surfaces, including your cell phones and computer or iPad screens. And strangely enough, although we all love and trust our family and friends, it is a good time to be asking them where they have been most recently. Did they go on vacation? Where have they been? We just need to be cautious about whoever we are in contact with and who our friends and family have been in contact with. This is the time to call your doctor, not to run into the doctor's office where there could be other individuals who may have had exposure to the virus. Also, large hospitals and clinics are really not the place to go. It's important to be in touch with your doctor by telephone or online. This is what we call the time for telemedicine approaches, where lab work can be logged into the central computer, and you have your computer code, and you can access results and either talk on the phone or get information by email. I would emphasize that right now it's good to have been in touch with your treating doctor, to have a plan of action, to coordinate your ongoing treatment, to make sure that you have refills for all the different medicines that you need on hand. And then also, if you have a fever, a cough, or are feeling extra tired, what is your doctor going to recommend, and have kind of a plan of action formulated ahead of time. And so those are just a few immediate suggestions about this virus. And so I think that what I'd like to do now is go to the panel for a question and answer with the panel. And so if we can start with Paul, maybe you'd like to comment on what the impact has been for the coronavirus in your personal practice, or if you have personal suggestions or comments. Paul? Maybe Paul's dropped off.
No, sorry guys, I apologize. I was just on mute there transiently. Thank you, Brian. That was an excellent summary you gave, and I really appreciate it because I think it's incredibly important. In Boston, unfortunately, we do have a very active situation because of the spread that originated from a Biogen meeting at the end of February. It's important to note, however, that the issues that you alluded to do seem to be so important. Social distancing, self-isolation, exquisite attention to barrier precautions and protection from transmission. I think in terms of what we've seen so far for our patients, I'm pleased to report that so far in my practice, there has not been a case of COVID-19 infection.
Okay, wonderful.
Yeah.
Fingers crossed, yes.
Yeah, and if I may, Brian, a couple of things I'd add is that I think obviously patients are being extremely careful and their loved ones as well. And I think that the important message is that, just as you outlined, which is this social distancing and obviously having a clear plan of action if symptoms emerge.
Okay. All right. Well, thank you for that. And so, Rafat, any words of wisdom on your side? How is it impacting practice in Indiana?
Well, I think we are in a similar boat like everybody else, so we have to be careful. And social distancing also will include, do you have to go to see your physician at this point? So routine follow-up, we're trying to avoid. If you're just on bisphosphonate and coming for your monthly, infusion or shot of denosumab, Exgeva, it's okay probably to delay it a month. So unless there's a serious medical condition that requires you to have in-person contact with your physician, we're trying to avoid right now. And obviously we need to, figure out the timing of transplant. If it can be delayed a couple months, that's okay. So social distancing in all format is very important.
Right, right. Very, very good points. And Yellow, from your patient advocate extraordinaire perspective, what thoughts come to your mind?
I think I want to mention a couple of things. This is a prime time for internet scams. So make sure that you exercise extra diligence when opening messages from people you don't know, emails, links without verifying the sender. Don't open attachments, all that things, because we don't want to be scammed during this time of need. And the second point is I think there is a mental aspect to coronavirus as much as there is a medical aspect to it. Patients get anxious. We lose similar when we were first diagnosed with myeloma, a sense of losing control with social distancing, being further isolated as a cancer patient. And as Dr. Abanar mentioned, there may be disruption of our treatment protocols, especially if you live away from a cancer center or take public transportation, and a lot of concerns around what do I need to do if I am on a clinical trial that is very strict and regimented.
Right, that's a very key point actually, and so this should be discussed with the trial doctor as soon as possible to have a strategy to, if treatment has to be given, perhaps go in at a quiet time, maybe even in the evening or something like that, where there would be the least chance of exposure. So things like that.
Yes, Brian, and if I may, Yellow makes an excellent point about clinical trials, and we're actively pursuing a strategy for those folks in long-term follow-up, say, and maintenance of clinical trials, of being able to not have them necessarily travel to the center, that we can do as much remotely as we possibly can. And our IRB has been very understanding of this, actually, and very clear that that this is a very appropriate response to the emergency. So therefore, we're doing that actively and helping our patients accordingly. And I think the most important thing for patients, as Yilak so nicely points out, is their treatment is consistent, it's under control, and it will continue. And you're absolutely right, Rafat, that there could be interruptions in treatment that may have no consequence. There's a few weeks delay here or there. Say someone who's been treated for the last 2 years or so on a maintenance strategy, a few weeks delay and lenalidomide therapy is not going to change outcome at all and could actually be perfectly reasonable to do.
Right. But these are things that, as you mentioned, Paul, need to be done in concert with the IRB, who I think can give immediate guidance and help on that. Okay, so we do have quite a number of questions that have been listed in the question box. There's one question about daratumumab. As you guys know, with dara, over time there is some immunosuppression and some risk of infection, and the question is about the continuation of dara in this current setting. And I think my answer to that is obviously there is some increased risk, but we do have that with a range of myeloma treatments. So probably the most important thing is to continue with the treatment, but certainly to discuss it with your doctors. Any particular thoughts about daratumumab from you guys?
This is Rafat. I mean, obviously the concern is with daratumumab is really reduce normal immunoglobulin. I'm not sure it affect your cellular immunity that much. So I think everything we do in medicine is risk and benefit. And if the drug is important for controlling your myeloma and preventing, progression, I think one need to continue with that. If, we are in the maintenance phase of treatment with daratumumab, maybe we can, a month, who knows? But I think it's always risk and benefit. You need to understand, if you lose control of your disease, sometimes that's hard, to establish control. So you need somebody to discuss that with details with.
Yeah,
absolutely.
Brian, I would very much echo Rafat's comments. I would stress, though, the point that daratumumab is associated with suppression of uninvolved immunoglobulins that are very important in bacterial infections. But Rafat's quite right that in the context of cellular immunity and in the context of antiviral effect, that we've no evidence that DARA would accelerate a viral process, except, of course, people have to be on acyclovir when they're on daratumumab for the herpes virus to prevent shingles reactivation. But I think Rafat touched on an excellent point, Brian, which is about IVIG, which is being often used for our patients who are on daratumumab therapy to replenish their uninvolved immunoglobulins, and that may be very helpful.
Right. All right. So there are a number of other questions, some practical ones. This actually came up in our office the other day, which was how do we make sure that packages and things that are coming in the mail are safe? And I don't know if anyone wants to comment on that. We got some mail and packages coming from Asia, actually, and how did we feel about that? Anyone want to comment on that?
I heard on NPR that on a cardboard the virus can last 24 hours, on a stainless steel is like 72 hours. But those are in a lab where everything is under control. But I guess the question is if the travel, and the temperature change and all that stuff. It's hard to know what to do. I think if you get a package, don't open it the same day. Open it tomorrow. Clean it up before you touch it.
Or wipe it down. I would certainly consider wiping it down. Someone on the line says maybe they would freezing food packages kill the virus? I think probably yes. Maybe stick them in the freezer for a while. But I think washing off is a good idea for sure.
Yeah. My understanding.
Another question which relates to the social distancing, and I think is an important one, with local travel domestically, a patient is concerned about hotels and restaurants. Does anyone want to comment on that?
Well, our advice, Brian, for our patients has been to minimize that as much as possible, and essentially it's all part of this whole construct of social distancing. And I think it's unfortunately you don't have control over environments like that. You don't know who's been there before, and whilst obviously in the context of restaurants and so forth, being socially distant from someone next to you on a table is appropriate, the issue really becomes restaurant workers and so forth. So we're being very, very cautious with our patients and advising, really stay at home. And I think that that's a reasonable message given where we are with things. I just wanted to add a point to Rafat's comment about packages. I completely agree with you, Brian, that these should be wiped down. In terms of the temperature sensitivity of the virus, it seems to prefer temperatures around 49 to 50 degrees. It's quite heat labile. Once things get hotter, that's lethal to the virus. And I believe also freezing temperatures from my ID colleagues are obviously also deleterious to it. But I think those are all very sensible precautions around minimizing the risk of transmission.
Right. Very good. Yeah. I think that this idea of not going to restaurants and really not even traveling locally if you can avoid it, and stocking up with food that you need at home, and remember that food can be delivered, and that might avoid going to the grocery store. I have to say that I was pretty amazed how busy it was at the grocery store, and possibly not a good place for social distancing, that's for sure. And there are a variety of ways of maybe getting food delivered, or just avoiding places that might offer a risk of exposure.
Dr. Dury, this is also a time, I think, to come together as a community. In our neighborhood, for example, there was a post on Facebook, neighborhood community Facebook, where someone wrote, if you are uncomfortable or not healthy enough to go to a grocery store or pick up your medicine, I would be glad to do that on your behalf. So taking advantage of neighbors while exercising social distancing may also make us a more cohesive neighborhood and community.
Absolutely.
Yeah,
I think it's
very well said.
Yeah. Absolutely. I think it's good to come together and try to help each other. And that applies to, just to be aware that younger people can get infected and are much less likely to have serious problems. However, they can pass the infection along. And so that it's important for everyone to pay attention to these social distancing ideas. There's a question to come up on the screen here about going to the gym. I think that my personal feeling is it's probably not a good idea to go to the gym where there are so many surfaces that could be contaminated. Someone wants to go swimming at the gym. I guess that might be okay, but with some caution.
I completely agree, Brian. We are encouraging our patients not to do that. It's obviously humid. It's sweaty. There's secretions. It's really not a good idea. I think you're absolutely right, Brian. There. Again, I think this is the time to echo your luck, of staying at home and pulling together as a community.
Right. There's several questions about stem cell transplant. As Rafat, a couple of people mentioned, if there's a scheduled autologous stem cell transplant, it's a good time to talk to the doctor about delaying that for a couple of months. If you have had a stem cell transplant in the recent months, then important to talk to your doctor carefully about supportive care, because there is a risk until your blood counts and immune system have a chance to recover in these coming months, and so definitely good to talk to your doctor if a transplant had been planned and if you have had one in the recent past.
Dr. Dury, how about vaccinations after a transplant? And you have had a transplant and you are due for a vaccination. Should you delay that?
I would be inclined to delay it. Yeah, there's a question that popped up on that. Yes.
Yeah.
Sorry.
So vaccination usually starts about 6 months post-transplant. If you just had an immediate transplant, I mean, I think, if you practice social distancing, it's, fine. I don't think you are at increased risk because you had, if your white counts recovered and the only thing I would like you to do is, really avoid crowds and avoid, having to go to the hospital unless it's absolutely necessary. And most hospitals and clinics now following better isolation procedures and protection of the patients. So I don't want anybody who had just had a stem cell transplant to be alarmed. I mean, I think, just follow what they taught you after you leave the transplant. Wash your hands, stay away from sick people. Don't go to church.
Right.
Don't go to restaurants.
All of that.
You will
Excellent. Yes.
Sorry, Brian, I just would emphasize, I really think it's important, this construct of social distancing for staying at home, because I really think that you're absolutely right, Rafat, for reasons that are obvious, church, synagogue, temple, all of these things are not to be done. And we really hope, obviously, the timeline of this will settle down over the next coming 1 to 2 to possibly 3 or even 4 months, but nonetheless, this will pass, and I think that the important point is that people maximize their chances of not being exposed.
Right. There's a question here which is a tricky one. Someone asks, what if a family member has recently returned from a trip? what should be done. And this is really a tricky point right now. The ideal thing would be for such a person to have a coronavirus test, actually, so that everyone would know if that person might have picked up the virus along the way. And so that would be a good option. Hopefully that might become feasible within the next week or so as the amount of testing available increases. I was pleased to see that a method from Roche will be made available in addition to a variety of other state lab tests will be available. And so hopefully it will be possible for more individuals to be tested, which would allow families to try to stay safe. If you don't know if a family member who has traveled or maybe went to the synagogue or maybe went to a concert or something like that and you're worried, it would be ideal to have that testing done. Otherwise, you need to, even within the family, consider a degree of social distancing.
Brian,
any thoughts on that from anyone?
Yeah, Brian, I would echo that. I think what we have to be aware of is that the testing issue is complicated, and I think there's been a certain politicization of it, which is unfortunate. But the reality is that there can be false negative tests depending on the viral burden. So I think it's terribly important to understand that, and it's terribly important. Again, I think safety first. If someone has come, a family member, again, you 2 or 3, 4 months from now, you can see them as much as you like potentially. The issue is now, and I would exercise extreme caution because, again, these tests can be false negatives. And this has been clearly shown in the Korean experience that patients have started off negative, converted to positive, and so forth over time. The most accurate technique is from the bronchoalveolar lavage, and that's obviously in the setting of someone with the acute respiratory distress syndrome. Intensive care.
Paul, comments. I think it's very important to consider the 14 days isolation if that's the case, somebody coming from Italy back or Spain. I think stay away from them for 2 weeks is not going to hurt anything. You're going to, as Paul said, you're going to do everything with them in 5 months from now.
Yes.
Right, exactly. So there's a question which is kind of the opposite, which is someone is saying if the myeloma has been relapsing recently and some new treatment is necessary, what should the patient do? And I do believe that that's what Rafat was talking about, that balance between managing the disease and trying to avoid risks. I think that the new treatment probably should be given, even if it might be intensive. The number one thing will be to control the myeloma, and this needs to be just organized in as careful a way as possible with the center and with the doctor to go in to get the treatment, but also to practice the social distancing. So I think that, I don't know if you guys have been doing this yet, where you might have people come in late in the day or even into the evening to avoid any crowded spaces. But I guess you might be open to that, right?
Rafat, do you want to comment first? Yeah.
No, go ahead, Paul.
Yeah, we certainly are already, Brian, because obviously we have a confirmed outbreak in Boston, and so as a result of that, we've been practicing exactly what you're describing, and at the same time maximizing precautions. And obviously, if a patient's disease is active and requires therapy, everyone is at all hands on deck to help. But exactly what you're saying, Brian, keeping patients synchronized in terms of timings, maximizing social distancing, and exercising all the usual precautions around therapy. I wanted to add one thing, if I may, Brian. I don't know if it's one of the questions, but one thing advice we're giving our patients is that if they're on Revlimid, for example, and they develop an upper respiratory tract syndrome, we are advising patients who are on Revlimid or on POM, or in other words, an immunomodulatory therapy, that it's wise to hold the Revlimid or wise to hold the POM, because we know that these things are immune modulators and can exacerbate an immune response. So if a syndrome is emerging and there's a concern, it's always wise to hold your medicine and obviously discuss with your physician. But that's certainly our strategy, has actually always been the strategy with Len maintenance and POM, for example, but is particularly important potentially now.
Okay, good points, Paul. Very good points. Another question relates to the risk for patients who have smoldering myeloma, I guess, or possibly MGUS. And I think that even in the evolving stage of the disease, we've been learning more and more that such patients are immune compromised, and so I think that I would certainly have due caution, even for a patient with smoldering myeloma or MGUS. Obviously, the big thing for such patients is that mostly they would not be receiving active therapy, and so there would not be that added risk of immunosuppression and low blood counts related to that. But I think that, again, due caution for patients with smoldering or MGUS. Any thoughts there, guys?
No, just like anybody else. I mean, I think it's very important. You know, every person in this country, until we figure this out, social distancing is very important.
Right,
yes.
right.
I would echo that.
There's
and
nothing
I
to
think
do about smoldering or mucus other than social distancing right now.
And
Exactly.
exquisite care regarding hand washing and so forth. Yeah.
Right. And there's a number of questions related to age. I think that what we're learning is that the infection is occurring for patients who are younger. It's just that the risk of more serious complications goes up with age, particularly into the 70s and the 80s. It does seem, for example, in Italy, the big problem is that they have had a high impact on the elderly population of Italy, which there's a lot of elderly people in Italy, and so this has had a unfortunate impact on the effect of this disease in Italy, where there are so many people in their 70s and their 80s, and so the age is definitely an important aspect of this whole outbreak.
Yes, I would concur, Brian. I think an important point, though, is to realize that obviously the severity of the syndrome does occur across younger people as well. Their capacity to recover, obviously, is a key point. The good news is that it doesn't affect children amazingly, although children can be infectious. The other piece of this is that, as you mentioned earlier, Brian, in 82% of cases so far, there is a mild to moderate illness. And this subset in whom problems occur is obviously, thank goodness, a minority. But the challenge, of course, is the extent of it. There is some important information to share about ACE inhibition and hypertensive medication. That ACE inhibitors upregulate the so-called ACE2 receptor in the airway, and this apparently is as a target for the virus. So this is something to discuss with the local physician, your caregiver for your high blood pressure, because certainly if you're on an ACE inhibitor, this is worth thinking about, because obviously if there's an alternative medication for high blood pressure that can be safely used, being off your ACE inhibitor may in fact turn out to be a wise move. Again, not something to be done without careful discussion with your care team.
Right, that's a very good point. Yeah, the coexistence of hypertension, diabetes, being somewhat overweight, a number of these things have for various reasons, impacted the problems with coronavirus infection. Okay, well, I think that we've really covered a lot of ground on this, and certainly we could come back to it if urgent questions come into people's minds. So unless people have some final thoughts, maybe we can move on. Any final thoughts about this COVID-19 issue that we're all faced with, or perhaps we can move on now?
Brian, my only comment would be one of great honest optimism. I think we will prevail through this, and I think for the myeloma community there is every reason that we can be very hopeful, recognizing all the caveats and precautions and the challenge, which is tremendous. And one very interesting snippet to share is that, interestingly enough, preclinical data suggests that proteasome inhibitors, boronate peptides in particular, have an antiviral effect. It remains preclinical, but clinical trials in China are actually being launched with bortezomib for the treatment of COVID-19. Though not that I'm saying that bortezomib or ixazomib will fight this disease, we simply don't know that. But it's, I think, just a word of a hint of a word of hopefulness for our patients as well, just to bear in mind some of these, I think, important things that we can do that I think will get us through this.
Absolutely. So let me just echo that. I think that it's very good to see right now that despite the huge problems in Asia, in China, in Korea, and Singapore, the number of new cases per day has dropped dramatically. And so it does seem that the wave of new cases passes through in a span of about 3 weeks, it seems like. And so the peak of problems is a very, very acute phase of about 3 weeks, which unfortunately that's where we are right now. But 3, 4, 5, 6 weeks from now, we could be hopefully looking at a time where the risk of new infections will have dropped to those levels that are occurring in Asia now. Another piece of good news is that even for patients who get very, very ill, the kind of shock syndrome that occurs in some people who get extremely ill, it seems to be something like a cytokine release syndrome, and can actually be treated with medications that we have recently been using related to CAR T-cell therapy. And so anti-IL-6 medication, what we call tocilizumab, and also steroids can be useful in that scenario, so that despite the fact that we don't have a proven antiviral approach, there are some good supportive care measures that can get sick people through the crisis point.
Dr. Dury,
okay.
One practical comment to mention is this may be a good time to double check, you have your will, you have your medical power of attorney, what to do with your loved ones if you are unable to care for them. And I don't mean just children or healthy husband or wife, but also pets, animals, plants. And you as a patient, what do you do if your caregiver is quarantined and unable to care for you? So this may be a time to plan for that when you don't need to actually have that.
Right. Yeah, it's a good time at home when we are quarantined. It's a good time to think about a lot of these different things that possibly we should think about more carefully in the big picture anyway. Yes.
All right. Brian, there's just one other thing. I'm so sorry. It was just a very important positive, which is, as you may know, some of the antivirals that have been under study have been showing considerable promise as well. So I think patients should really know that there are some effective antivirals that are in the clinical trial pipeline moving very quickly. That certainly preliminary information suggests benefit. So very important for patients and families to hear that.
Absolutely. This retroviral from Gilead, for example, has shown actually quite promising results in China and I think elsewhere. And I think that we should look to see if this can be made available on a trial basis in the U.S. as needed. I haven't heard of anyone being able to have access to it yet, but hopefully that can happen.
No, it is. Brian, just to reassure people, it is. There was a case report just published in the New England Journal of a man in his middle 30s who had a full recovery from the syndrome, and he received the antiviral therapy on a compassionate emergency use basis. So there is
that
access.
Was good. Yeah, was that the gentleman up in the state of Washington? Yeah.
Exactly.
Yeah, that was. Yeah, there was a gentleman in New York, the lawyer in New York, who was trying to get it, and so I was tracking that to try to see if that might happen. And so hopefully there can be access for people who really need it. Okay. So we can come back to any points on this, but let's move forward and cover some of the normal things that we usually talk about related to myeloma, and just go through from diagnosis, frontline therapy, maintenance, and then into the relapse treatments. So if we move forward, I'm just going to show a few slides about the current approaches to frontline therapy, and then we can have some discussion about what does our panel currently recommend in this frontline setting, and then take questions from our listeners today. So obviously, thanks to Rafat for this particular slide, when we're managing myeloma, we have the initial or frontline therapy that can be used in the transplant setting, or if a patient is ineligible for transplant, and then we move forward either with the transplant and maintenance, or consolidation and maintenance, and with supportive care along the way. And so the great news that all of us on this call have been involved with is the shift from a limited number of drugs that we had for so many years to all of the exciting availability of so many new options, all the way from the relapse use into the frontline setting. And if we look at the new options in the frontline setting, we obviously have the doublets such as Velcade Dex on this slide, Revlimid Dex, the triplets, Velcade Cytoxan Dex, thalidomide Dex, Revlimid Dex, and then also the option for Kyprolis, Revlimid, and Dex. The big question that we face right now is whether adding daratumumab as a fourth agent to the triplets in the frontline setting will be the way forward, and this is one of the things that has been a big question for the last year or two. So what is the best frontline therapy, and should we be looking at using a triplet but perhaps adding daratumumab to that? And that's what I ask in slide number 18. Now, at the recent American Society of Hematology meeting in December, a variety of studies were presented where daratumumab was combined basically with all the different triplets that we frequently use. The results from the Cassiopeia trial were presented, in which daratumumab was combined with Velcade, thalidomide, and Dex. This was a large randomized study, and so with the IFM presenting Philippe Moreau, and so it was really exciting to see the much deeper responses when you add daratumumab to the VTD, and you can see a significant increase in traditional response at the VGPR and CR levels, but also MRD, and they listed at the 10⁻⁵ level increased undetected MRD. And so I give this to you as an example of the benefit in the deeper responses and hopefully ongoing longer remissions and improved overall survival with a 4-drug combination versus a 3-drug. The results with daratumumab plus VRD were also presented, the Griffin study, also daratumumab with KRD were presented. And so we have a lot of data looking at this idea of combining daratumumab to give a 4-drug combination versus the traditional triplet. And so if we go to slide number 14, I guess that number is correct, where we have the algorithm for frontline therapy for a patient who is not a transplant candidate, for a patient who is perhaps frail or more elderly, Revlimid and Dex, a doublet, or VMP can be used. For a healthier non-transplant candidate, Dara can be combined with VMP, or VRD is certainly an excellent option and can be used in the form of VRD light as proposed by Paul, actually. And then we have the new exciting possibility to use daratumumab, Revlimid, and Dex based on the Maya trial data. For transplant candidates, the big question is whether we should use a triplet such as VRD or backup regimens of VTD or VCD alone, or perhaps combined with a DARA-based quadruplet. And then in the additional treatment phase, autologous stem cell transplant, and then maintenance for a standard or a higher risk patient, in which lenalidomide could be combined with a proteasome inhibitor. And then thinking about what is the current role of transplant. Certainly on the European side, there is no delayed transplant outside of clinical trials. I think that there's probably an important degree of flexibility on the US side and elsewhere. And so if we can have, first of all, I'll leave this algorithm slide up here, and perhaps maybe Paul, you would like to comment first on how do you see the options for frontline therapy evolving right now? I don't know if Paul is there. What happened here? Hello? Have we lost
It looks like his mic is on mute. Can someone unmute, or does he need to do it himself?
Or Rafat or Yelek, are you hearing me?
I'm sorry, Brian.
Okay,
Brian,
we now
I apologize, Brian. I'm sorry, Brian. No. So someone had, the organizer had me muted because the organizer has to unmute me. Otherwise, I can't go on. I'm sorry about that. Folks, yeah, I'm so grateful for the opportunity, Brian, to comment on this because it's such a dynamic space. I think the exciting news for patients is the 3-drug platform plus the antibodies are generating unprecedented qualities of response, and not only just depth and breadth of response, but durability, particularly with the impact of lenalidomide maintenance. And I think that has had such an extraordinarily beneficial effect broadly. And I would agree with all of the comments you made. I would simply add that we're now in a position to tailor our 3-drug platforms plus the 4th drug the best patient outcome based upon the characteristics of their disease, even considering their genetics and so forth, that can allow us to best understand what the best platform is. You make a very good point about delayed transplant. We obviously have been exploring this for some time, and just very pleased to report to you that so far on the determination trial, with now approximately 4.5–5 years of follow-up and 70% interim analysis done, we can't call a difference yet between early versus late transplant, even for progression-free survival, let alone overall survival, where studies have shown no difference. So I think that obviously we'll have hopefully full information next year, but right now our French partners at the same time had full information and it showed a PFS difference but no OS difference. And the fundamental difference between the French study and ours was maintenance. The duration of US maintenance has been continuous and until progression. And it seems that lenalidomide maintenance has proved a true equalizer in terms of effect, at least so far. So we're very pleased to see that. It's a great outcome for all our patients, those who had the transplants early or late. And I think it echoes the point you make about choices in the US for sure.
Right, absolutely. So Rafat, what is your perspective about a triplet versus a quadruplet? Are you seeing that we would move towards that? And then maybe comment about the current status of stem cell transplant.
Sure. Yeah, thanks for the overview of where we are today. Yeah, I think, we all know that response matter, depth of response matter. People are going to enjoy longer life without the disease when you really eradicate the disease to undetectable by sensitive assays such as the minimal residual disease measurement. So I really think it's, we made progress when we start using, Paul's, combination of Revlimid and Velcade. I think we are going to make more progress when we add the monoclonal antibody. You saw the Cassiopeia study and the Griffin studies all showing higher rate of complete remission, all showing higher rate of minimal residual disease. I think if we achieve a sustained complete remission and a sustained minimal residual disease, I think we're going to start talking about cure. So I think getting rid of myeloma is a good thing. And I'm so glad to see this day where we can use 4-drug regimen to induce such a deep response. So I'm really very excited about that. The question is, would you still need a stem cell transplant when you have such great eradication of myeloma? We don't know. I mean, and Paul, summarized his experience that he's been leading for a while. I mean, I think it's probably very important that we collect stem cells and store them early on for a rainy day. But, if we start designing trials based on the depth of response, we may be able to answer that questions. But I think we should aim early on, as obviously, with respecting the quality of life of the patients, minimizing side effects. Let's try to shoot for a complete remission in MRD negative state as early as possible. I think that's going to translate to long-term benefit. And
Absolutely.
So transplant may not be needed, but still we don't have any data to support it completely. So if you don't want to do transplant, collect stem cells and store it.
Definitely, definitely. And so from the patient perspective, Jellic, how do you view the idea of having this kind of a 4-drug combination? Obviously, more toxicity and more expense, but as Rafat emphasized, driving down towards deeper levels, MRD negativity, et cetera. What's your perspective?
Yeah, absolutely. Dr. Dury, this is a time for myeloma patients that's unprecedented, right? We get one drug approved almost every other day, and this is a good time in general. But as you all said, today, myeloma still is not curable. So which means that we need to decide based on risk stratification who benefits from a 3-drug combination versus a 4-drug combination, because I feel like we still need to pace ourselves if I'm going to stay as a patient for the next 10 years, 15 years, or 20 plus years. I think that is one area that I would like you guys to discuss a little bit more. The other one is around maintenance. I am not a fan of maintenance forever, but I think, as Dr. Paul Richardson said, maintenance seems to be a difference maker on how long patients end up being PFS or their overall survival. But I would like to see if that can be guided through some testing using the minimal residual disease testing or something like that, as opposed to all patients getting maintenance forever based on the whatever previous drug that they have received.
Yeah, very, very good point, Jellic. And I think that we do critically need those kinds of studies where we can look at achieving MRD negativity or undetected, as a new buzzword in this setting, and then decide if it's safe and appropriate to stop maintenance after a certain length of time if a patient does achieve MRD undetected. My personal perspective is that we'll need at least a couple of measurements so that we would have the concept of sustained MRD negativity, not just one reading, but 2 readings, perhaps 6 months apart, as a minimum, as a decision-making process. Any thoughts on that?
I would completely agree, Brian, that this MRD construct and tailoring therapy according to these outcomes is a very exciting way forward, and still, in my opinion, an area of very active research. I'm not sure it's quite ready for prime time, and the reason I say that is the following. We know that MRD is variable depending on the treatment setting. For example, if you look at the MRD status of patients after CAR T therapy, it appears relatively unstable. Whereas in the context of induction remission treatment, maintenance consolidation, it's a lot more reliable in our experience. But I think that points to a key key construct, that MRD is a new tool, but we really need to be careful how we think of it and we go forward with it. I think there's this real entity of MRD negativity of the host, actually, which is an area of really important research, looking at the immune profiling of the patient that may be very important in terms of improving outcome. But broadly, I would absolutely agree with Yelak that it will be great to tailor therapy. And I love your point, Yelak, about a strategic view. Thank goodness these days, we are looking not at 3 to 5 year survivals as medians, but looking at 15, 20 year survivorships in our practices.
Right.
To me, is the privilege of being part of the myeloma community. It's wonderful to see. And I think we therefore have to realize the implications of what we do initially may have an impact later. And this is an area of very active research as well, Brian, because
yes.
Melphalan is a wonderful old warhorse, but it is an old warhorse. It is, just to be clear, phenylalanine mustard, and that's a soluble form of originally mustard gas. And the reality is, as a chemotherapeutic, it's very potent and it's extremely active against myeloma, but it is nonetheless genotoxic. And one of the worries we have is that, what does this genotoxicity in the long term do? If you expose your patient to cytoreductive therapy that is highly genotoxic, do you incur genetic injury both to the patient's stem cells and their myeloma that later, 5, 10, 15, 20 years later, may bite you? And that's a critical area of research. Now, that's very much an evolution, but it's a definite consideration. And I think that we've got better drugs now to get us to that point. And we've got, actually, very interestingly, just because I had the privilege of working for Tim McElwain, who was the founder of high-dose melphalan and stem cell support. And Tim said to me way back in 1990, if we can get away from high-dose melphalan, it will be a service to our patients. But having said that, the reality of newer drugs that can achieve the same thing seems to be there, including, actually, for that matter, highly targeted forms of melphalan in the sense they're very different, actually, but they are in a stemness sense that may get us to the same goal without the same issues. So I think it's a really exciting time to have the choice of this and to be able to tailor treatment accordingly, as Yelak so nicely outlined.
Very, very good. Yeah. So we're touching on some questions that are coming from the audience. One was, could the better therapies move us away from transplant, which you've been touching on. Another one bears on substituting Ninlaro for Velcade, which I think is certainly something to consider. And I know perhaps Yelak would be a good person to comment on that.
Yeah, absolutely. So I switched from Velcade to Ninlaro when Ninlaro was first approved in November of 2015. And by January, I switched to Ninlaro and was on it for about 3 years before I discontinued that and changed it to a different therapy. But I think it is, in a maintenance setting for me, it was very effective. I tolerated it well, and I like my doctors, but I didn't have to go to the doctor's office as often, which was a blessing for me.
Yeah, very, very good. And then another question, a similar kind of question, is that with the recent approval of isatuximab, which we were pleased to see in combination with pomalidomide and dex in the relapse setting, how do we view that moving forward? The question is about in the frontline setting, and there are some studies going on now, trials with that, but right now we don't have data related to isatuximab in the frontline setting. Anyone like to talk about that as a daratumumab alternative? It was good to see the approval in the relapse setting.
Rafat, do you want to go first, and then I can comment in a moment?
You did the study, so go ahead.
Okay, no problem. It's my privilege to have been part of this Picaria study group, and this was an international trial, and actually Dr. Michelle Attal and I were the principal investigators. It's so interesting, Brian. Isatuximab is fascinating. I think it's important to realize it is different to daratumumab. It binds to a different epitope, and it has different effects that qualitatively, preclinically, are quite striking. Whether they are translating into the clinical setting remains to be seen. But my feeling is, I'd love Rafat's thoughts on this, that, for example, in lymphoma, we use Rituxan as part of CHOP Rituxan, we use Rituxan plus ICE, Rituxan plus EPOC, as we treat our patients sequentially across the natural history of their disease. I think myeloma is a lot smarter than that. And I think that, we're going to be needing to use different CD38s at different times. So my inclination is that whereas daratumumab clearly is translating into tremendous benefit up front, it may be very important, for example, to have isatuximab in combination with other drugs that can then meet the challenge of when the disease breaks through daratumumab. And it may be an important construct to understand. Similarly, it may be worth noting that isatuximab has different side effects. And the issue there is so important because what it can do is be given to patients with chronic obstructive pulmonary disease and asthma much more safely than Dara's, in my experience, very safe, but you have to be very cautious in patients who have pulmonary disease. And I think there are aspects of that which may be also relevant as we go forward. But I'd love Rafat to comment more.
Yeah, so I'm clearly impressed by the data you presented and published on the combination of the new anti-CD38 with pomalidomide. So I think the question is, will this be a different drug that will be with different side effect profile, can be used in patient who's been exposed to daratumumab before with maintaining activity. I don't have any data. I don't have any experience yet to comment on that. It's good to have more options. I think makes it easier for us to take care of patients. I would love to have more data to help me out.
Absolutely. It just take time for that. But I think in the short term, we do have the shorter infusion time, which is helpful. And I think it will be more cost effective, I think, also. But these are things we need to see and see what will be the positioning of isatuximab moving forward. Okay, so I'm going to move forward now. I think that, hold on a second here. There we go. Sorry about that. So we've already touched on this, but the next phase is obviously what are recommendations for maintenance. Paul already emphasized that, for example, in the Dana-Farber study, as compared to the IFM 2009 trial, maintenance can be a very important aspect. And so slide number 17, I talk about, well, what are our current approaches? And I think the answer to that is that we do, in general, recommend maintenance therapy, primarily with Revlimid, for patients who might have the higher risk features such as 414 and 17p minus, and possibly even 1q plus, I guess. Combine Revlimid with a proteasome inhibitor. A key issue for patients that comes to me all the time is modifying the maintenance because of side effects, including just day-to-day intolerance or reduction in blood counts, particularly white blood cell count, with perhaps infections, upper respiratory or urinary infections. And so the issue of stopping maintenance for intolerance, and as we were just talking about, related to achieving an MRD negative status, does become an important discussion point. And so there are quite a few issues that come up, both for doctors and for patients, related to the use of an ongoing maintenance regimen. And so maybe I'll open up this for discussion. Maybe, Rafat, you would like to comment first in terms of your current practice, in terms of the choice of treatment, and then the duration of the treatment that you use for maintenance.
Yeah, obviously we try to divide the patient into what we call standard risk and high risk. high risk based on cytogenetics, if they have, the P17 deletion, high risk for what? Short, time without progression. So for these patients, we tend to use both the immunomodulatory drugs and proteasome inhibitor, Revlimid plus Velcade or Revlimid plus Ninlaro. And for standard risk patients, we use Revlimid, as the vast experience around the world showed that it's beneficial in delaying progression, improvement of patients' overall survival. But I think we always, with any treatment, you have to have an ongoing assessment of risk and benefit and side effect. I think it's very important that, you pay attention to the fatigue, to the drop in the counts, the diarrhea, whatever, side effect that may occur during, the treatment. You have to try to manage it as effectively as possible. At some point, you may need to stop the treatment, give a treatment holiday, resume treatment. The question is that, do you need, maintenance forever? I think I would love that, question to be answered in the era of novel combinations, such including the monoclonal antibody. And, now we start doing clinical trials with monoclonal antibody in the maintenance setting. Do you need to, can you stop after 2 years? We need to do the trials. I think we owe it to our patient to do the right trials, where maybe, there's non-ongoing therapy forever. Maybe after 2 to 3 years, we start saying, okay, if you keep this markers, whatever it's MRD negative at 6 months, 12 months, 24 months, see a complete remission at 6 months in addition to the MRD negative. Is that a good thing at 6 months, 12 months, 24 months? Hopefully we'll have those trials that will help us answer that questions. But today, I think for standard risk, Revlimid alone. For high risk, Revlimid with Ninlaro. Duration is always, as long as you can, but also address the side effect profile, adjust accordingly.
Yeah, absolutely. I think that we would echo these comments. Any additional comments from anyone? Let me just say, there's a question that came in, which doesn't come up a lot, related to the development of reduced levels of testosterone. Is that something that you see as a side effect or concern that requires attention?
Yeah, Brian, obviously we see that in men after transplant. Yeah, after transplant, we definitely see that. As a side effect of lenalidomide, though, I'm not. We certainly see thyroid deficiency, but low levels of testosterone from lenalidomide, no. Typically, testosterone deficiency occurs post-transplant, and that would bring me just on to another comment, because I completely agree with Rafat. I think the important point is that maintenance strategies initially were built from the post-transplant setting. So because of challenges with tolerance of maintenance post-transplant, because of suppression of blood counts and so forth, we typically have said lenalidomide alone post-transplant in standard risk, as Rafat says, and then add a proteasome inhibitor in high risk. Interestingly enough, in the non-transplant setting, it's certainly our practice to continue the lenalidomide and the proteasome inhibitor in a maintenance fashion if you do not use high-dose therapy, because with the rationale behind this is obvious that you'll not cytoreduce the tumor in the same way with high-dose melphalan, and therefore, if you're going to continue with a maintenance strategy, it makes sense to be a little more proactive, in our opinion. And therefore, we do that. Now, of course, if you're high risk, it's a given. But even in standard risk patients, depending on tolerance, we will pursue that. One very interesting thing we've learned from the determination trial, which is this early versus late transplant study, is that actually post-transplant, it's sometimes more difficult to deliver dose and schedule of maintenance than it is in the non-transplant setting, which is an important finding in a prospective randomized fashion.
Right. Very, very important. Okay, so I'm going to go ahead now into what is very important for many patients, is what to do if there has been a relapse occur. And the good news is that we really have a lot of options. And the question is frequently, which of these various options would be recommended in a particular setting. And so in slide number 20, I've just kind of summarized what are the options in an early relapse setting with the key discriminator based upon the maintenance which would typically have been used, which would be lenalidomide, and whether a patient has become refractory to lenalidomide or not refractory to lenalidomide. In other words, if the disease has progressed despite the use of Revlimid and what would be recommended, or if there is felt to be some continued sensitivity to lenalidomide and what would be recommended. And so the exciting information is obviously the availability of daratumumab Rev-Dex, and then also the option for Kyprolis daratumumab, which actually was just recently approved, and so a few options to talk about there. And then for patients who are refractory to lenalidomide, the pomalidomide options, the daratumumab proteasome inhibitor options, and then options for patients who are more frail. And so I'm not sure who would like to go first on this. Maybe Rafat, would you like to comment first on how do you approach or what are your preferred choices for the refractory and not refractory patients?
Yeah, so I mean, obviously, we treat a patient, based individually. I mean, each, that's the good thing is that we really have several options that will address patient preference, patient medical conditions, and the type of relapse, the biology of their disease. So I think, your algorithm here is, interesting based on refractory versus non-refractory. But also we have to pay attention to, is it biochemical relapse? Just your myeloma markers are going up? Are you having a symptomatic relapse? What your preference, oral regimens versus, intravenous regimen, and the medical conditions of the patient, how far they live from the clinic and things like that. So there are a lot of good options, I think. And those, require that the treating physician sit down with the patient and address all of them, and take the time to make that decision. Clearly, I mean, I think, even in the relapse setting, even in the relapse setting, I think triplets are superior to doublets. So I rarely use doublet in the relapse setting. I'd like to use, triplets, so a monoclonal antibody with, either pomalidomide or lenalidomide, and pick the right proteasome maybe in that combination. I find that pomalidomide is a very good, Pomalyst is a very good immunomodulated drug. It's easier to use. You can manage the side effect quickly. So I like to use it in combination. We have two monoclonal antibodies, in the relapse setting that can be used. So it's the patient preference, the type of relapse, the biology of their relapse will influence any of those, combination that you put on the slide 20.
Right. Yeah, you made a number of very, very important points, the patient preference, and then I think particularly important, the use of a triplet versus a doublet, and then obviously a pomalidomide-based regimen, especially for a refractory to lenalidomide patient. And so Paul, what perspectives would you give for a patient?
I think Rafat, I fully agree with all the comments from Rafat that really, rarely do we necessarily go to just a doublet. The doublets can sometimes be valuable in the setting of biochemical progression and where you're minimizing toxicity. But I fully agree with Rafat that a 3 or 4 drug platform makes sense in the relapse setting because it's to sort of paraphrase the old quote, relapse disease is guilty until proven innocent. And I think that that's an important paradigm. I think in addition to the comments, I mean, I absolutely agree with Rafat about POM. It's a very useful drug in this setting as a backbone. And obviously we've got the enormous benefits of, after upfront bortezomib, we can then deploy carfilzomib, we've got ixazomib. All of those gives us good choices. I think the interesting part of the slide, Brian, which is very informative, is, if Dara refractory, what do we do? I think that's become a new challenge because obviously we've generated strategies to tackle lenalidomide failure, but when daratumumab fails a patient, what do we do? And I think that's an important area in the relapse setting. And I think there the combinations you suggest are excellent. We will often use carfilzomib with cyclophosphamide as a platform there. And now, obviously, with the approval of isatuximab, there's an opportunity to bring that in. But of course, also, there are other options. And I'm sure you're coming on to this, Brian, but there are new drugs like selinexor that you could think about, because I do think the Dara refractory population really worry me. That's a population in whom disease can behave very badly once Dara has failed a patient, and I think that's an area of importance.
Right. Yeah. So I'm glad you emphasized the point in the setting of the Dara refractory, because I see some questions coming up related to that, and it is encouraging. Even I think that maybe you could comment on the value of the ELO POM-DEX combination. I have to say I was quite surprised to see that this was quite beneficial in this setting.
It's fascinating, Brian, and I'm glad you raised it. This is the ELOQUENT-3 trial. Now, the ELOQUENT-3 trial combined elotuzumab with pomalidomide and DEX and showed a striking difference in favor of the three drugs over the pomalidomide DEX platform. So after daratumumab runs out of benefit for a patient, there may be a role for ELO-based platforms. I think the natural killer cell activity is the key, and the fact that in the ELO-POM-DEX platform, which is FDA approved, there is a relatively DEX-sparing approach. This may be very important because, as you may know, Brian, the ELOQUENT upfront study, the ELOQUENT-1 study, the press release was that there was no significant difference seen between the two arms, ELO-RD versus RD. I think one of the issues there could well be the dexamethasone dosing, as well as, frankly, that pomalidomide is much more of an NK cell activator preclinically than lenalidomide is, although both do it, but POM to a greater extent. So ELO can be very useful. I personally, I love Rafat's comments on this too. When I use ELO after Dara failure, I will basically go ELO POM plus a proteasome inhibitor, because I feel you need probably more than just the EPD.
Right. Okay, and so I flipped forward to the next slide, 21, which includes some of these additional options that you were starting to touch on, Paul, including obviously the selinexor and some of the other, the isatuximab POM-DEX, which was recently approved, etc. I don't know if there can be any added comments about these additional options.
Sure. No, I'd welcome Rafat if you'd like to start, and then I can come in, because this is a great slide, Brian. Thank you for bringing it forward. There's a lot here to discuss for sure.
Yeah. So obviously we have.
You were touching on sort of the new. Paul, you were, initially you were going to talk about some of these new in clinical trials, so the CAR T cell bispecific antibodies, and the rest. So I'll let you do that. But we have options, and so when somebody relapse, I love the way you said it, that relapse is guilty until proven otherwise, especially early relapse. You want to try to get rid of the disease. And so triplet, quadruplet, whatever is appropriate for the patients and based on their medical conditions, we should try. Because, every time the patient relapses, we do not do as well with subsequent relapses. If we don't get it right the first time, we have to get it right the second time. So when the patient relapses, let's give them the best chance to get into a remission, to get into MRD negative. So there are a lot of good options, and again, it's not going to be, in somebody who has an early relapse, you're not going to go with 2-drug regimen because probably you're not going to be able to control the disease. Try to get the disease under control, 3-drug regimen, 4-drug regimens, and then you can start backing off to a maintenance regimen that is not a 4-drug regimen. So it's a great option. You can see all these drugs here. So let's get it right at the first relapse.
Very, very good. Perhaps, Paul, I could ask you first, just for your thoughts. On this slide here, we have the selinexor, and my impression is that since the approval of selinexor and the use has spread in the community, the results I have been hearing have actually been surprisingly good, or perhaps better than had been anticipated, related to concerns about toxicity and the like. Well, what is your feeling about what has happened with the availability of selinexor?
Yeah, I completely agree, Brian. I think what people have to understand is that in the STORM study that it was a privilege to be part of, we had to go for an accelerated approval offering a combination of 2 drugs, selinexor and dexamethasone, to patients in whom every other drug class had failed them. And so therefore we were up against a real hurdle. And the fact that a response rate was seen, and in patients who responded, there was durable responses that were clinically very meaningful, was remarkable. And that provided us accelerated approval. We then had at the ASH meeting an excellent presentation by Dr. Christine Chen from Toronto. She showed that the combination of selinexor and pomalidomide was particularly effective and actually quite well tolerated, to your point, Brian, particularly with the weekly dosing. And now finally we have the results of the Boston trial, which again, it was a privilege to be part of, in which we showed, and this was led by Nazir Avalis, but basically Nizar showed that the combination of bortezomib, selinexor, and dexamethasone provided a substantial clinical benefit over the control group. Now, what was really interesting in the Boston trial is that we designed it so that the bortezomib would be given weekly and the seli weekly. And in this context, the toxicity of the regimen of the experimental arm was substantially improved, actually. Less neuropathy was one of the key findings. And so as a result of that, this is going to be very exciting data going forward because it shows that this platform could be very beneficial to patients. So I think people are aware that the Boston study, that there was a public announcement about it and some of these details were shared.
Right, exactly.
Hopefully we're looking forward to being able to share more information. But it gets to your point, Brian, that, when we use it, when I use it as it's approved, frankly, I use it weekly. I typically combine it with either bortezomib or carfilzomib. There's very nice data from various investigators on that. Dr. Cristina Gasparetto actually did some lovely work with selinexor and carfilzomib. And between these combinations, selinexor is delivering a new mechanism of action, which I think can be very important.
Very, very good. Okay, so let's move ahead. So any final points before we... Yeah.
If I may, Brian, just one class of drug that I know, in Dana-Farber, we've always been very near and dear to our hearts, and that's the histone deacetylase inhibitors. And I think panobinostat sometimes has been, actually, to be honest, is sometimes forgotten as a very reasonable option for patients. Particularly, again, it's like selinexor. If you use it according to the classical schedule, it's challenging. But if you adapt it and reduce dose and change schedule, it can be very effective. The reason it's particularly important, in my opinion, is once daratumumab fails a patient, for example, it can be very effective in upregulating CD38, restoring responsiveness preclinically at least, and it remains to be seen how much that will translate into the clinic. But nonetheless, it's an important option to combine with other drugs. There's very nice data combining panobinostat with lenalidomide, led by Dr. Acharya. There's a very nice paper published recently by Dr. Elizabeth Manasach from MD Anderson, where she combined RVD and panobinostat, and it's published in Lancet Hematology. And there's actually a little jewel of a study from the British back in 2016, published in Lancet Hematology, where they combined bortezomib, thalidomide, dexamethasone, and panobinostat. And in that study, amazingly, in a relapsed refractory population, 60 patients strong, they had a 90% response rate. So I think sometimes people forget that drug really has a potential, and if it's properly taken forward, which it is under new ownership, in fact, no longer with Novartis, new team, Secura Bio, I'm very hopeful we'll see more benefit from panobinostat helping patients going forward.
Thank you for those comments. And in fact, there was a question about panobinostat, and so I'm glad that you were able to touch on that for this listener today. So thank you so much. And so I'm going to move into the final segment for today, which is the more novel agents. Obviously, we have the novel combinations. We were all very pleased to see the CANDOR data that we've touched upon, Dara-Kyprolis dex at ASH. And some of the other combinations, the iberdomide, the new IMiD-like agent from Celgene, now BMS, exciting new data, the melflufen new agent, and then an unusual lipid raft radionuclide option. But I think that without a doubt, what we can touch on at the end, just to give some very, very positive news for our listeners, is just to touch on what we heard about the immune therapies, the CAR T therapies, the bispecific T-cell engagers, and then the monoclonal drug conjugates, particularly the belamaf, the GSK compound. And so if we take them one at a time, I think that the presentation of the CARTITUDE study, which was the results of the Janssen trial, and Janssen had taken over the results from the Chinese Legend data. And so I think that everyone was extremely pleased to see the very positive results with the CAR T product based on the Legend product. And it was presented by Deepu Maduri. And she made this interesting point during her presentation that actually 100% of the patients did respond, and that the toxicity was really remarkably good, and so that we do need to pay attention to a treatment where all the patients at least benefit somewhat, and a majority of them have really quite deep responses. And so this was followed later by another ASH abstract looking at the T-cell engager from Celgene, now BMS, the CC93249. And this was a dose response study presented by Luciana Costa. And on this graph here, moving from the bottom to the top on slide 26, you can see that very, very nice dose response relationship with excellent deep responses with significant benefit using this T-cell engager, linking the T-cells with the myeloma cell to enhance that anti-myeloma benefit. And then we also had results from the GSK product. I didn't show the slide here, but also a 67% response with the GSK monoclonal antibody drug conjugate. And so we clearly have major activity with these exciting new immune therapies in the relapsed patient population. In this case, I selected the ones which are targeted against B-cell maturation antigen, the BCMA targeted therapy. And so big questions about how we see these new approaches moving forward. And so, Paul, I think that maybe you could comment first, and then maybe Jellic, you can be ready to jump in as to how you view this from the patient perspective. So Paul, do you want to comment first about these various amazing new immune therapies? Paul must be muted, I guess. I don't know. someone asked while we're waiting. Someone asked a question about BiTEs. The T-cell engagers have different names. The one that came from Amgen is called a BiTE. The one that comes from Celgene and BMS is called a T-cell engager. So there are different words and names for these T-cell products.
Brian, I'm so sorry that I am back on. The organizer kindly unmuted me, which is.
No worries. And so maybe just give you a broad perspective about these exciting data and how do we view this moving forward? Obviously, we are so happy that patients with relapse refractory disease have been able to benefit and have remissions on an average of about 1 year. But how do we look at this moving forward?
It's a great question, Brian, and I think the important message for our patients is that, you know, after CD38 targeting, we've now got a whole armamentarium that can go after BCMA, which is a very important marker in myeloma. A critical point is that the CAR T therapies have gone from strength to strength. We've got the efficacy of the BB2121 platform that's now well established, and in that same setting, establishing platforms from it that actually can generate memory potentially, and so enhance durability of potentially of disease control. And as you very nicely outlined, Brian, there's the excellent data from the Janssen team, the CARTITUDE studies, led by some super investigators who've done some very nice work. I think the important message about the GSK platform, which it's been a privilege to be part of actually, is its off-the-shelf capability. I mean, you can just pluck it out of the pharmacy, as it were, and infuse patients every 3 weeks. It's a relatively well-tolerated infusion in my experience, and it's very active. You kindly touched on the DREAM-1 data, where we saw a very solid response rate, around 60%, as you pointed out. DREAM-2 in the truly penta-refractory population, you know, in whom all treatments had unfortunately failed them, we saw about a 35% response rate in that group of patients, if one looks at it overall, because there were actually 2 dose levels explored. But my point is that it's a very important new platform, and I think that as you think about CAR T and you think about GSK, we've got 2 potentially very exciting new approvals this year, if all goes well, for these agents. So I think it's tremendous. One thing that is worth noting is that I mentioned earlier that MRD negative disease after CAR T appears to be somewhat unstable. And I think that in that regard, strategies aimed at maintaining response are absolutely critical. And there are a variety of ways that can be done, both immunologically as well as thinking about new maintenance agents. One point that we touched on earlier was the sort of stemness that's such an important part of this in the disease, that is. And you touched earlier on the drug melflufen, and it's actually a very, very important new agent, in my opinion, for potentially going after this. It is a sort of great granddaughter of melphalan, and it may actually be able to target the stemness without the toxicities that we see from traditional melphalan. So I think BCMA, very exciting. Some challenges with stemness in BCMA targeting. On the one hand, for CAR T, perhaps maintenance is the way to go. For GSK, because it combines a chemotherapeutic, it actually may have a little bit more control on the stemness, perhaps. We don't know, but possible. And then there are newer strategies going for stemness as well.
Very, very good. Yeah. So Jellic, from a patient perspective, what's the level of excitement? What is the thinking or prioritization and thinking about CAR T, a BiTE or a T-cell engager, and the GSK product, which is off the shelf and most likely will be approved rather soon?
Yeah, I think this is a really hopeful time for myeloma patients, and there is a feeling that the future is very hopeful. But I think, as you both mentioned, none of these therapies are yet curative, and more research needs to be done, and tweaking of the CARs need to happen over a period of time, hopefully sooner than later. And I think a lot of the struggle that I'm hearing from patients that have gone through these therapies and the therapy has failed them is they don't know what to do next. So there is a need for clinical trials that are, in my opinion, bold and takes the patients that have been treated by one of these drugs and put them in some sort of clinical therapy.
Right. I sense that as well, already seeing patients in that situation. Maybe we can cycle back to that. Rafat, do you want to comment first about the positioning of these, and then perhaps we can touch on what's available for a patient who may relapse on one of these therapies? Rafat?
Sure.
Yeah.
Well, first of all, I mean, I think, last decade was the decade of Revlimid and the Velcade, the immunomodulatory drugs and proteasome inhibitor. I think this is a decade of immunotherapy. It is fascinating to be able to take patient own immune cells and make them a myeloma killer cells. It's incredible. And, we are at the start of this era. We just starting. So I think the technology is going to get better. We're going to use them probably earlier. They're going to be more specific. They're going to be more safe. They're going to be more sustained. I think it's just an incredible. And, the conjugate antibodies, the BCMA conjugate is also incredible. And we're blessed to be able to be part of these clinical trials to see how quickly you're getting a response. So I think it is exciting time. It's really exciting because we're going to have these amazing technology, conjugated antibody CAR T cells, bispecific T cell engager that will be part of our treatment, and I think they will be moving forward into clinical trials for, upfront. We don't have to wait too late to use these drugs. If we're going to start thinking about a cure, we want to get rid of myeloma. Getting rid of myeloma is the first thing. Putting patient into a CR, complete remission, putting them in MRD negative, minimal residual disease negative state, and sustain, that's what's going to cure people. So it is very exciting to see these drugs, available to the patients. And I'm sure a couple of them will be approved this year. We just have to figure out how we're going to use them, how we're going to use them better. So, it's just an exciting time. I mean, there are a lot of clinical trials going on that we have, Dana-Farber has, everybody has, that will addressing the patients who have relapse on the monoclonal antibodies and the like. So it's not the end of the world. I think it's just an exciting time.
Absolutely. So a couple of questions came in. One of them, is there any update on CRISPR? I think that at ASH, there was the preliminary data using the CRISPR technology to modify T cells. This was from the University of Pennsylvania, presented by Ed Stadmeyer. And so certainly, I think that this CRISPR technology can be used to gene edit T cells and enhance them in a variety of ways. And so this is just one of the other approaches that is exciting at this point in time. Another question is, do we track soluble BCMA in the blood, and there are some data on that, but I don't believe any of us are doing that in any kind of routine way. Would anyone like to comment on that? Is anyone tracking BCMA in the blood at this point?
Not routinely, Brian. I would say that it's a very interesting research question, because obviously you touched on this very important point, and Yelak brought it out. What do you do when BCMA targeted therapy fails a patient? Where do we go next?
Right.
And I think it's an important construct, because knowing what the BCMA target may be doing, it may be very relevant. Interestingly, in the CAR T space, there was this focus on the degree of expression of BCMA and its importance, and that seemed to sort of actually not be quite as linear as you might think, that in fact BCMA underexpressing patients did also respond. So it's a complex question. I think the important message to echo on Rafat's comments is that after BCMA targeting therapy does run out of steam, I do want to emphasize for patients we have options. As you know, Brian, selinexor-based therapy after CAR T failure was effective. And in the same spirit, we touched on melflufen in the current single-arm phase 2 trial after CAR T failure. We've seen responses from melflufen-based approaches. So we have strategies that can go after this. But I do agree it's a very important area, and Yilak nailed it by saying, we need to be looking at this very proactively, and we most certainly are. The one thing I would stress here in the CAR T space after CAR T treatment that's so exciting to me, as you talked about it earlier, Brian, are the cell mods, the so-called CT220 and CT480, and very interestingly, there do appear to be responses to these cell mods after CAR T therapy. So it's very important for patients to hear that we really are going after this area. And in there, perhaps I clue that, after CAR T, perhaps maintenance with either 220 or 480 may be a very important strategy going forward.
Very, very good. Yes, yes. Another question which we can touch on is, are we making progress in making these therapies safer, both CAR T and BiTEs or T-cell engagers? And so I'll just comment that it was actually quite nice to see that in the CARTITUDE study, that Legend product, the safety profile was really rather good. But I would also say with the BB2121 platform, the tolerance has been good moving forward with some adjustments of management of CRS and the like. And obviously there was another study presented, a Chinese study, which had a built-in safety switch within the engineered T cells. So any thoughts about the safety of these immune therapies?
Well, Brian, I would just...
Brian,
sorry, I thought you go first. Go ahead, yeah, please.
That's fine. What I'm saying is that I think we, current CAR T cells, the signals, looks encouraging. I just want to let you know that there are several companies that are coming up with CAR T cells with really the goal, two things: improve specificity, make sure that you're getting the right target and you're eradicating the myeloma and the second one is to improve safety. So I'm excited that there are several companies working on both the CAR T cells and the bispecific T cell engager, and I'm sure we're gonna nail a couple of those that will be very effective and also very safe.
Right, yes, I fully agree.
I would echo that. I would say also, Brian, that obviously new strategies to CRS beyond the IL-6 antibodies are being developed because they can be very important in reducing some of the issues that surround the CRS and neurological syndrome. But I absolutely agree with Rafat that the newer approaches may be particularly promising. I am struck that the BB2121 platform seems very safe, actually, in the larger studies that have been done. But I do think, like all of these things, you unleash the immune system, you have to be extremely careful. And the Legend platform clearly is more potent, but I think it's important to keep a beady eye on that one going forward from the point of view of, so for example, using it in older patients, maybe perhaps exactly. So that's important. For GSK, I did want to add one very important point, Brian, which is this ocular toxicity that had been a worry for the platform. I will stress that with dose and schedule adjustment, that has become much less of a worry. And the combination trials, which we'll be hearing more about this coming year at the various meetings, are really exciting in that regard. When you combine 916 with other drugs, the keratopathy, which is what it is, particularly if you go with lower doses of GSK, really doesn't become the issue that it was when we were just using it as part of monotherapy. And the other good news is that we've learned a lot about the ocular toxicity and have got really nice mitigation strategies built around dose and schedule, and most of all that can make it a very manageable approach.
Absolutely, and I think it is really exciting to have that off-the-shelf option moving forward with a likelihood of approval and with a management strategy, a mitigation strategy for the ocular toxicity. There is another question here about using a BCMA-targeted approach for first relapse versus one of the novel triplets that we were talking about. My sense is that we're we're probably not quite there yet with these therapies in a first relapse setting, unless possibly for a really refractory patient. We would certainly need some trials in that setting first. Yep.
Yeah, Brian. There are ongoing clinical trials trying to also address, some of these novel approaches such as BCMA CAR T cells in first relapse that happening in the first year or first 18 months, because obviously we know that early relapse after good treatment indicate that there's a high risk myeloma, difficult myeloma to treat. So it makes sense to test these novel agents in that setting. And I think we will learn from the ongoing trials whether this is effective or not.
Exactly. Okay, so I think we're coming towards the end of this, what I think has been a really, really fruitful session, touching on a lot of very important points. And so I'm coming to my final slide here, which I summarize some expectations for 2020. The GSK molecule we just talked about, we are expecting that it would be approved. Also, for the BB212 and the Legend CAR T platforms, both of those are moving forward with the potential for approval. Also, the melflufen, we're hopeful that there will be an approval for that. The exciting results coming out of ASH, the quadruplet studies, DARA VTD, the Cassiopeia, DARA VRD, the Griffin trial, DARA KRD, and then also we are using KRD and DARA KRD in the what we call the CURE trials for high-risk smoldering myeloma, which we didn't really talk about today, but those results will be coming forward in 2020. And then the new agents, the cell mods and this I-131 molecule, which does have some value in relapse refractory patients, and other agents in this really, really active myeloma space, which is exciting for all of us to be a part of, which is something emphasized by Rafat. And so with that, I think that we're moving towards the witching hour here, or witching 2 hours. And so perhaps I'll go down our panelists here for some final thoughts for the day before we close this special GoToWebinar session. So yeah, Paul, would you like to go first?
Sure, or if you would like to go first, whichever, or Rafat, what do you think, Brian? Would you like me to just some...
whoever wants to jump in. Yeah, like, you want to go first. Yeah.
Well, as a patient, I'll jump in.
So you jump in.
This is a very hopeful time for us patients, and I think a great time to be a myeloma doctor and a myeloma researcher. And Dr. Dury, as you dived deeper into the presentation, I couldn't help but notice the increased options and related complexities of being able to decide what to do next. So I believe with that increased option and increased complexity comes a responsibility for you as a myeloma experts to consider patients' options and opinions, and for us patients to be able to articulate our needs and be an informed participants in our care. So I think it is really important to be able to consult with a myeloma expert, but more importantly, not just consult, but build a long-term relationship with a myeloma expert, so the myeloma experts can direct our care based on our choices, including clinical trials.
I fully agree. This concept of joint decision making is so important, because the efficacy, the benefit, the convenience, all these different things. It's the patient who is the consumer, and we need to have that as a central part of all of our discussions. And so, Rafat or Paul, whoever would like to go next.
Yeah. So I think, I look at dealing with myeloma is really a teamwork, so you got the patient, you got the caregiver, you got, the treating physician, the nurses, the myeloma expert. I think we need all these, people together partnering toward, really helping the patient get the best treatment for them, because I think each myeloma is unique and each patient is unique, and to have goals of therapy that are clear. I think today is just amazing. We bless how many drugs we have and how many combinations we have.
Right.
We just have to use them in correct way with clear, and again, clinical trials are very important. I encourage my patients to participate in those. That's how we're going to make progress. I think we should be bold. We should start thinking about clinical trials that aim to cure the patients. I mean, I think this is a great time. We shouldn't be shy of trying to design the right clinical trials to hopefully get patient into a lasting complete remission. That's how you cure patients, a lasting complete remission. So we need to start thinking about that. It's the time, but again, it takes a team from the patient. We need to, listen to the patient, listen to the caregiver, engage the nurses, the treating physician, the myeloma expert, to try to provide the best care possible.
Absolutely. And some questions have come in related to this aspect of attempting to cure myeloma, which you didn't really touch on today, but the ASCENT trial, which actually Rafat is a part of, is ongoing in the U.S. using daratumumab KRD in patients with high-risk smoldering, and this has been moving ahead strongly now, and the results of that, how successful we are in achieving an MRD undetected status, we'll be able to have preliminary results on that this year. Also, another Black Swan project.
On that trial,
yes,
as you know, Brian.
Yes.
The first patient is just to tell people, it's a 2-year therapy, and we stop. And so the first patient has 1 more month left in the 2 years therapy.
All right.
Doing great.
Yeah.
This is fantastic. Yes. So go ahead, Paul. Yes.
Yeah, very briefly, I'll just echo everything that you so kindly said, and Yelak, and of course Rafat. My final comment would be that we're blessed now to be sitting on 11 drugs approved, 3 drugs coming in a modality this year. That will generate for us, because one drug we didn't mention was venetoclax, and that may well be approved this year as well. So we may be sitting on 14 and plus 1, that'll be 15 modalities and treatments going forward. So I do agree. I think that the construct of achieving durable remissions that will last decades are potentially within grasp. And I think in that spirit, thinking strategically as well as tactically is so important. And I think both Yelak and Rafat touched on it beautifully. The essence of teamwork is key. I just wanted to close by thanking you, Brian, in particular, and Susie and the IMF team for making such a fabulous webinar possible today. And the last comment I'd make is please everyone be safe and get through this very challenging time with COVID-19. I'm very hopeful for us in the future, but we must be very careful now.
Thank you so much for that. Your cautions in the times for us. And just a final comment on the big picture that was asked here. We have the Black Swan Iceland project, where we're looking at this other aspect of myeloma, which is the early evolution of the disease, the development of MGUS and smoldering myeloma, what is causing that, and how we can intervene even earlier to try to make a difference. And so for that questioner, this project is moving forward strongly, and again, there will be updates during this year. And so let me just say, again, very, very difficult times. I hope that we were able to help you with questions that you might have about the impact of the COVID-19 coronavirus and and that we have given you some hope and helpful advice about all of the great options that are indeed available for patients with myeloma. And so with that, I would like again to thank our sponsors who have made this possible to modify and have this GoToWebinar today. And then I'll turn it back over to our hosts, to Robin Toohey and Susie, who I think will have some closing comments.
You are absolutely correct, Dr. Dury.
Okay. All right. So go ahead, please.
So, Robin, I'll go first and then you go. But I'm having a big, serious echo. Anyway, Robin, I want to thank you for being my. I'm having such trouble with it. I have to hang up.
Oh, all right.
It's okay, Susie. I'll pick up. I know Susie was very, very happy for this seminar to be an online webinar. So all of our friends in Boca and all over the country were now able to participate. And I think the information we got today was very hopeful and helpful, not only about myeloma, but about the coronavirus and ways that we can all take action and be safe. So I know there were some questions about if this was going to be available for replay, and the answer is yes, that it will be available for replay early next week, and you can access this and all previous IMF webinars at myeloma.org and click on IMF videos. Susie also wanted to make sure that people knew that with the growing concerns over the coronavirus outbreak, that the IMF wants to ensure you still have access to our resources. However, with a focus on the health and well-being of the staff, the IMF has decided to close the office, and it is the right thing to do. And we still are here from you. We're all working from home, and you can email us, and you can still contact the info line, and they will be answering questions as they are able to and as they come in. So again, I'd like to mention that many of the local myeloma support groups have canceled their in-person meetings, and the IMF is helping to facilitate and coordinate online meetings similar to what we're doing right now. So before you get in the car and drive to a meeting, check with your support group leader, look at their website to see what those decisions are being made for March and April and as we go forward. I wanted to mention to the caregivers, please remember to take good care of yourselves too, to stay safe and well. While we were on this call, I just accepted my husband's mail order for Revlimid, and I took some precautions when signing for that package. I wore gloves, I wiped the package down with some antibacterial wipes. So please just take those extra steps to be safe and to stay well so you can be there for your loved ones. And as we wrap up, let's not forget that March is Myeloma Action Month, and the IMF website has many ways for each of us to take action and to show our resilience. And you can find the link on the IMF's homepage, myeloma.org, and those photos and stories on the Myeloma Action Month wall of resilience are truly inspiring. And I think at this time, we need to feel that love and hope and information. So let's have each of our actions amplify this awareness and information so we can all move forward. Don't forget, the IMF publications are available for download on the IMF website. And some of the events that have been postponed right now, just to keep you up to date, the IMF Regional Community Workshops in Birmingham, Alabama, Kansas City, Edina, Minnesota, and Detroit are all postponed, but stay tuned to the IMF website to get more information.
All right. Well, thank you so much for those words. I think we're going to have to close out the.
Yes. Can you hear me?
Yes, go ahead, please.
This is one of those days, but I'm very excited because we heard so much new information and how far we're going in getting ever closer to the cure. And I know I'm sounding kind of, but all I'm hearing is myself. So I apologize, but thanks to everybody, and we really appreciate it.
Thank you for those really positive words. I mean, I think that we all are feeling strongly these days about trying to stay safe and also to be positive about all the good things that are happening for myeloma patients everywhere. So thanks tremendously to the panel today. Paul, Rafat, and Yelek, thank you so much. And thanks to all of you for participating with your excellent questions. And we will be following up. And stay safe. Thank you.
And we are one myeloma nation.
Yes. There we go. Thanks to you all. And have a safe rest of your weekend.